Okay, hello everyone, and thank you for joining us again on this episode of the Cal and Coca Report. We have the pleasure to have David Heyman, who's an American physician and epidemiologist based in London, UK, who has held leading positions at the WHO for more than 20 years, coordinating global responses to epidemics such as Ebola, AIDS, polio, and SARS. He also served as chairman of Public Health England from 2009 until 2017. Professor Heyman has received numerous career awards, including being named Commander of the Order of the British Empire in 2009, and also served as editor of the 18th through 20th editions of the Control of Communicable Diseases Manual, a publication of the American Public Health Association. On August 5th, 2020, Professor Heyman was deployed as part of a WHO search team in South Africa to help strengthen the national and provincial responses to COVID-19. Professor Heyman, welcome back.
Thank you, Michel.
We're very happy to have you on. Last time you came on the show with your colleague, Professor Fine, we talked about, in general terms, we talked about the concept of herd immunity, because at the time it was a kind of a hot topic during the COVID pandemic. I think we had you on back in October. Some people were making claims that in certain parts of the world, herd immunity had been achieved. Others were more skeptical. There were different models. But I recall from our conversation and from the paper that you published with Professor Fine that these models have to be taken not with skepticism, but their practical value may be limited. I mean, they're nice theoretical models, but on a day-to-day basis, the practical value of modeling for herd immunity is limited. Now, in May 2021, after another wave of severe epidemics throughout the world, it seems that was the correct stance, would you say? Or what did you learn regarding herd immunity in this, with the second part of the epidemic?
Well, Michel, I think everybody would agree that this infection is becoming endemic, like the 4 other human coronaviruses. And so we have to learn to live with it. And we're really extremely fortunate that we have so many vaccines to choose from and diagnostic tests and even some therapeutics, including some monoclonal antibodies. So we have to learn to live with this. But every time a person gets vaccinated or gets infected naturally, there's an immunity which develops. And that immunity causes a herd immunity effect in the population because it decreases the transmission of the virus from people who are to people who are immune against infection. So we're seeing that there is a herd immunity effect. This virus came into a population which was completely naive, no antibody at all to this infection, no immunity. And now we're seeing that there are significant numbers of people who have either had vaccination or infection themselves. And so we're seeing that there is a decrease in transmission, even though some of these virus variants have increased transmissibility, because transmissibility doesn't only depend on the virus. It depends on the environment, what the antibody level is in that environment, and it also depends on behavior of people. Mm-hmm. And people transmit viruses, and if they're paying more attention, doing a risk analysis or a risk assessment themselves, and trying to prevent infection of others, that can go a long way to the herd immunity effect.
Right. No, clearly, I think those are excellent points. But what I was alluding to, I think perhaps was more specifically the idea that one could predict a certain level of prevalence beyond which things would get better, or that sort of a kind of precision that the modeling invites. Perhaps we have to, right.
Most modelers, I think, suggested between 60 and 80% there would be a herd immunity. What they meant was there would be a stopping of transmission. I don't think that that's possible at present with this virus. It's mutating, it's escaping some antibody, some antibody effect. So I think that we will see it continue to transmit at a lower level, absolutely a lower level, because of the immunity in the populations. But this idea of herd immunity, even for measles, the modelers project maybe over 90% immunity, which you need in order to stop transmission, but then it rapidly increases if it's reintroduced into a susceptible population. So I think it's better not to talk about herd immunity for this disease, but to talk about an environment where there's increasing immunity, and that will modify the epidemiology of the infection.
Right, right. Um, Can we had on the show in recent weeks guests from India during their their most recent surge in March and April that was really terrible. Anything particular about India where that you think explains why they were so overwhelmed or seemingly so overwhelmed later in the course after having gone through a fairly substantial epidemic to begin with?
Well, I think that as in all places, this virus finds ways to transmit, and all viruses do. And they gave it a big opportunity with the Mela, the big festival that occurred on the Ganges, when all these people gathered together very closely, very few wearing masks to protect others. And then they returned to their communities. And many of these people would have been Brahmins, because it's the Brahmins who do these festivals, and they would be the middle class. And my colleagues in India tell me that the epidemic that overwhelmed the urban areas has been an epidemic of the middle class. It's not been an epidemic of the poor in those cities. However, it is spreading now, it seems, into rural areas. But this virus doesn't cause serious illness in people who don't have comorbidities or who don't have obesity or are elderly. And so those people mainly congregate in the urban areas, the middle class.
Mm-hmm.
And that's why they've had such a terrible time in urban areas. That's what my colleagues tell me. And it seems now that it is decreasing. They've been able to meet the oxygen demands to save lives and to decrease the burden on hospitals.
Right. So you just mentioned earlier that COVID will be endemic, will be just like one of the other coronaviruses and so forth. What does that mean from an epidemiological standpoint or in terms of an intervention standpoint? Does that mean that we shift? I mean, the strategy of contact tracing, isolation, and that sort of thing, is that essentially now set aside? We learn to live with it. Of course, now we have the vaccines, and so that changes the equation completely. But generally speaking, what does that mean when we determine that a virus has become endemic?
Well, I expect we need to keep track of where this virus is, and we'll need to, if there are discrete outbreaks, try to stop them like we do for tuberculosis or like we do for other endemic diseases. When it occurs, try to understand, trace the contacts, understand where it came from and where it's going, and try to stop it. But there will be large parts of the population which are protected against it, we believe. We don't know yet whether the vaccine is preventing completely against nasal carriage in the nose passage of the virus, and whether that will, in fact, make it continue to spread. But we believe from studies that the level in the nasal passage of people who are vaccinated is very low. It's below the level that it could be transmitted. So hopefully it won't transmit from people who are vaccinated. And, the control program will be other things as well. Maybe they'll want to screen at certain events where they think it's high risk. Screening has been shown to be effective. If you screen people before they go into an area with a rapid antigen test, you can detect those infected. So there are many ways that we'll get back to normal, but I expect that within a year, we'll be pretty much back to the way we were before. There's an interesting study, Michelle, that was done back, I think about 2005, where they did a molecular clock analysis of the coronavirus OC43, which is endemic in humans. Are you aware of that study?
No.
I think it's very interesting because what it shows is they took the specimens of OC43 that they had from the 1950s up to 2005, and they genetically sequenced those viruses. And then they did a molecular clock analysis to determine the rate of mutation. And they went backwards to a place where they had also gone backwards from the bovine coronavirus, which is where this is thought to have come from. And they came to an intersection about 1888, 1890. And during that period of time, there was the Russian flu pandemic,
Hmm.
which people thought was influenza, never had a specimen, but it had some neurological signs and symptoms. And so these molecular biologists hypothesized that this was the emergence of the coronavirus OC43, and that it gradually became endemic over time and mutated in a way that it became less virulent.
Right. So is that one of the viruses that causes a minor respiratory infections?
Yeah. The four coronaviruses cause minor respiratory infections, maybe more severe in the elderly, but it's
Right.
the common cold virus. It is
Right.
a common cold virus.
So is that, I mean, I've heard the argument being made by at least one infectious disease expert who's not a prominent academic, but he was making the argument that it would take, that was before the vaccines came on board, but he said it might take 4 or 5 years, and this current, this COVID-19 virus
Yes.
would eventually become less and less virulent as the natural history. But then I've heard other infectious disease experts dispute that possibility, or saying you can never tell, and that sort of thing. What is it? Does it depend? Is it just a wait and see approach, or?
I expect we don't know enough to say exactly what might happen,
Mhm.
but as more and more people become immune to the infection, it'll be less and less serious, especially if those people who are immune are the people with comorbidities. So we may see it. The one caveat of all this is long COVID, which we really don't understand. I think it's called long
Right,
hauler,
long haulers, correct,
long
yes.
haulers in the US. But we do know that there are long haulers from mononucleosis. There are not long haulers from many other viral infections. So what we're seeing, we need to better understand. But I expect that eventually this virus will calm down and become something we can live with. Whether or not it mutates in a way that it becomes less virulent or less transmissible, I don't think anybody can predict.
Okay. And what is your expectations for countries like New Zealand, perhaps China, that um, don't have very low immunity from the natural infection, who will now become vaccinated, presumably, or I don't know how far they are along their vaccination campaigns. But do you think they might be at some increased susceptibility just because there's less natural immunity, or?
Well, I think with the efficacy of the vaccines, no, if they can get their populations vaccinated, they'll be protected against serious illness, but it will likely become endemic in those countries.
Mhm.
It will eventually come in and become endemic as they open up their travel. But I think what they're trying to do is be prepared for that by vaccinating their populations. And hopefully the anti-vaccination movements won't interfere with that.
Right. Good. David, if I can switch gear a little bit and ask you
Sure.
to reflect a little bit, generally speaking, it's a topic, obviously, of great controversy. I don't want to drag you into sort of political discussions or positions, but what do you think generally of, um, given our experience this last year, of the role that epidemiologists and public health experts end up playing in a country, or a given political community's response to an epidemic? Is it too much? Is it not enough? I mean, should they be given more authority, given less authority? Should they just be advisory and let the political process make the decisions? What's
Yeah.
your perspective on this?
Well, Michelle, I think the most difficult dialogue in this pandemic has been that between the public health leaders in countries and the political leaders.
Mhm.
And the political leaders have seized upon this pandemic in many countries as a way of showing their population how strong they can be and how wonderfully they're protecting their populations. They're doing this in order to decrease the burden on their hospital systems. That's what most countries are trying to do, is to keep the burden low on their hospital systems so they can manage patients and get the other patient backlogs into the hospitals as well, because there are big backlogs. So, the public health voice has been weaker than the political voice in many, many, many different countries. What's going to happen now is that there'll be more and more dependence on public health people to help populations understand how to do their own risk assessments and their own mitigation activities and their own prevention activities, because the government has done it for many countries now.
Mhm.
They've just forced physical distancing by locking down. Now people have to understand that mask wearing can protect others. If they want to protect others, they should wear that. If they go into crowded spaces without a mask, they might become infected if they're not protected. So they need to make sure that if they're visiting family members who might be susceptible, they can do it just like we do with other infections. So the problem, I think, will be for governments to wean the people off this, we're doing it for you, to you do it for yourself.
Right. How likely do you think that will happen? I mean, um, I, I see what you're saying, but on the other hand, it seems that the response has been so strong that the expectation will continue to be that the governments will step in. In what way do you think the? I mean, in a way, it has to be. Um, the political authorities have to allow this to happen, um, and will the public health, I mean, isn't it better from a public health standpoint that precisely that the communities be more educated and be more responsive in and of themselves, as opposed to being kept in a state of dependence and then perhaps
Yeah.
react in other ways and do the wrong things, or because it seems to be breeding a lot of skepticism. You have this skepticism about vaccines. I think vaccines have been terrific, but a lot of people seem to be anti-vaccines just because of the association that it seems to have with government policy and so forth.
Well, I think that what you're saying is true. Once governments let go, then the public health leaders will take over. And they'll be doing the investigation of discrete outbreaks. They'll be working at the local level, helping people understand how to assess their risk. They'll be doing the contact tracing. And it will be what a normal infectious disease approach is for other infectious diseases. This is really a disease that has a mortality level that's not extremely high.
Mhm.
When you look at a little bit over 3 million deaths in a world of 7.7 billion, there may be double that number of deaths or even more, but even so, it's not a major, as Mike Ryan at WHO always says, this was not the big one. And this is one that governments reacted to very violently because their hospital systems were threatened, especially in countries such as European countries where health systems are a part of the government activity, trying to make sure that there's equitable distribution of healthcare.
Right. Although it seems, I mean, at least in the US, that maybe at some point, early on, there was I mean, at least from the perspective of some, and it's perhaps my perspective, that the systems, the chance of the system being overwhelmed, the healthcare systems, the hospital systems, it was clear after a couple of months into the pandemic that that was not going to be the case. That the US has really a very large capacity. Yet the governments continue to, at least in certain areas, continue to institute fairly severe lockdowns on the argument that it might always, I mean, because there's always the possibility that if you let go, that you will be over. I mean, it's hard, right? No one can predict. It's not a controlled experiment, so you never know,
Right.
and you can always make the plausible argument that the more severe lockdowns and restrictions are necessary to keep the systems from the healthcare systems from getting overwhelmed. Should the public health authorities then at this point say, no, this is too much, it's okay, the healthcare systems are not going to be overwhelmed, you can let go?
Yeah, I think that's what has to happen. Although in Europe, the health systems were overwhelmed.
Right.
They were overwhelmed and they weren't able to meet the capacity that they needed. But I think now they're watching very closely hospital admissions, and that's what they're using as a decision point as to whether or not they need to, what they will need to be more severe in their measures. In the UK here right now, they're talking about the 21st of June being free again. And they're gradually, I just was walking out on the streets and the pubs are all open and people are having a good time.
Mm-hmm.
And they're not wearing the masks. When you go into a supermarket or into the shops, you're wearing a mask. But, people are trying to get back to normal. I think last year when they unlocked, they just unlocked overnight and people didn't really understand that they needed to still pay attention and they weren't vaccinated. this year now there are so many who are vaccinated, and there's a greater, I think, understanding of the infection. And I think maybe the unlocking will go fairly well. They're worried about the India variant right now, as you know. But, as long as it doesn't, it takes a naive population for it to really expand rapidly.
Mhm.
If there's immunity to it, which it appears there is,
Right.
then, fine.
Right. Um, uh, Apart from the question of perhaps um, closing borders, do you think the public health people should be more decentralized? I mean, more, it should be a locality based, because I mean, public health to some extent is always going to be involved with the political authorities. I mean, right? I mean, there won't be any private public health organizations. I mean, it will always be. But do you think that it should be more decentralized, more locally based? Maybe a given town in the UK, Birmingham, having its own, being allowed to set its own policies as opposed to London and places like that.
And, I my career was with CDC. I was seconded to various places, including WHO. And CDC is the group that should work with Washington to set the policy framework around this.
Mhm.
Well, here's what is best practice. Here's what you should do. But implementation must be done locally. It must be facilitated by state policies that copy the federal policies if they feel they're useful. But there's only contact tracing, public health is only accomplished with trust. And that trust is best developed when you're working within the communities that the people know you and they trust you. So trying to centralize contact tracing, trying to centralize public health activities has never been shown to be effective in the past. And I can't imagine that it would be now. Where you do the contact tracing, where you look for the people who have sexually transmitted infections, is at the local level where there's trust, not at a central level or not by a telephone app. Although apps will certainly be helpful in the future, but they can't replace face-to-face trust.
Right. I agree with that. I mean, I think the trust has been a key victim, I think, of this last pandemic, and I certainly hope that that it will be rebuilt. How is what's happening at? Uh, are you still involved with the WHO at this
Yes,
point, or
and one of the committees, yeah.
is the mood more relaxed in a way, or what's?
Well, this past week was the
happening?
World Health Assembly when all the ministers of health get together, and it was by Zoom this last week. I didn't participate. But I think, I think WHO will be relieved that that's over now. There's been a lot of criticism. There was an internal national panel which looked at WHO and made some recommendations. I think the major recommendation of that external evaluation was that heads of state must be engaged in a solidarity movement. You can't have solidarity unless heads of state are willing to do that. And there are actually some movements to begin to create possibly a treaty. The Europeans are behind this, which would guarantee that people will work better together in the future when there are pandemics such as this. So, that may take off. That might become something which supports working together. But WHO has always provided the technical guidance, best practice guidance, and they'll continue to do that, I think, fairly well. They use the evidence. They're slow, they're bureaucratic, but they look through vaccine information. They give emergency licenses to vaccines, things that are very important. And so even though it is a big bureaucracy, I'm sure they will continue to play an important role.
So the criticism or what was being reviewed, was that the early response or the relationship with
Everything, yeah.
China being allowed to go in
Yeah,
and understand, right?
the politics of WHO, one of the recommendations was that a director general should only be elected for one term, 7 years, and not reelected, so that would remove the politics from being, so a whole series of things.
Right. Okay. Well, Anish finally joined us here, and I wonder if Anish, do you have any? We've been speaking for about a half hour. I know you were tied up and you couldn't join us.
No, I didn't realize. I was sorry. I was tied up. I'll just listen.
No worry. Okay. All right. Well, we may be wrapping things up here, anyways. But David, what's next for you? Are you um, involved? I mean, is your focus continuing to be on COVID-19, or now do you think it's
Yeah,
is
no,
going to go back to
I continue to work on a few different things. On COVID, I'll continue to work on. Along with Rosanna Peeling, who's an expert from the London School of Hygiene and Tropical Medicine in diagnostics. We're working with the Wellcome Trust, which is the charity for research in public health in the UK, trying to better understand how rapid point of care diagnostic tests can more rapidly enter the market in a valid format. Because what's happened during the pandemic is that all these diagnostic tests have been given emergency licenses, but they haven't been validated externally. And so many of them have a very poor predictive value or a very poor sensitivity or specificity. So we're trying to get regulators and policymakers to work together closer to the time when these tests begin to be developed so that they can be rapidly put out. So that's one project, still along the lines of public health, and a few other things along the way.
that's an interesting topic to me. Do you think? I mean, does regulation hinder the rapid development of more accurate? I'm kind of a pro free market processes in general, and take the vaccine for example. The regulators require very large clinical trials, for proof of documentation, which naturally delays the adoption of vaccines. These mRNA vaccines were technically available very early in the pandemic, and I always wonder if it would have been possible to allow the vaccines to be released, perhaps in a controlled manner, but we would have seen they're so effective that we could have seen efficacy very early on. And what are your thoughts on this?
That's right. You can't compromise for safety, and you can't compromise for quality of production. But you have to look at the risk benefit in licensing, and they don't do that. In the US, it's zero risk tolerance, whereas in other countries, the risk may be different than in the US. And so, but unfortunately, WHO bases its pre-qualification of manufacturers on this zero risk desire, which is what the FDA and the Medicines Regulatory Agency in Europe require. What's more important, though, Michel, is that countries get together and harmonize their regulation so that it doesn't have to be done 2 or 3 or 5 or 10 different times. Some countries won't license unless they've done the clinical trials in their own country. That's something that we have to look beyond. We have to get countries that are like in epidemiology and in genetics, for example, to begin to harmonize their regulatory procedures so that one doesn't do it and another have to wait. The single dose Johnson & Johnson vaccine just got recently this week got licensed in Europe, and it's been licensed in the US for 2 months. It's ridiculous that they can't get together and harmonize.
Right. I mean, I wish they would go away altogether. as regulators, they won't. They won't. But at least, I mean, there should be a voice saying, "Listen, I mean, we can reasonably make a reasonable argument that a lot of time was wasted, and therefore a lot of lives in that sense."
Yeah, and if you look at the rotavirus vaccine when it was developed early on, it was licensed in the US. Other countries licensed it. The pre-qualification at WHO licensed it with a zero tolerance of risk. Then when intussusception occurred, WHO, because the FDA pulled it off the market, WHO did. And during the period of time when it was off the market, think of the number of children who died from rotavirus infection because they weren't vaccinated. The risk benefit was different in developing countries than it is in the US, and 9 intussusceptions would be nothing in a developing country where rotavirus is killing children every day. So there's got to be a change in the regulatory procedures, and that's why Rosanna and I are working to begin with on diagnostics, then we'll move to drugs and vaccines.
Amen to that.
We'll see.
David, thank you very much for your time. It's
Thanks,
been
Michelle.
terrific.
Nice to talk with you again.
Take care. Bye bye.
Bye-bye.